Hello! Welcome to the second in the series of therapy videos. Today we're going to talk about some specific therapies. In the previous video we talked about general approaches to therapy. So today we're going to talk about specific behavioral therapies for phobias and OCD and depression and anxiety. So these all kind of fit within the general cognitive behavioral therapy kind of umbrella, though not necessarily right into the main rational emotive type that we talked about in the previous video. So you probably remember what a specific phobia is from a previous video. If not, test yourself right now. See if you can come up with the definition of a specific phobia. It is a fear and avoidance of a particular stimulus, heights, blood, spiders. Behavioral techniques, as we've already also discussed a little bit, are typically the treatment of choice of specific phobias. And in fact, systematic desensitization therapy, the process of slowly exposing the client to more and more fearful stimuli while engaging in relaxation, is truly a process of extinction. It is a process of deconditioning a classically conditioned association between a stimulus and a overly intense emotional response. And as we've also previously discussed, this can sometimes be done with virtual reality. So if you're looking for a little more detail on that, you can skip back to the lecture that talks about specific phobias, in which I say most of that same stuff, just in maybe a tiny bit more detail. There are a couple of other methods for treating specific phobias. There are cognitive strategies, like increasing patients' awareness of the thought processes that maintain that irrational fear. So first off, you have to have a patient who realizes their fear is irrational. If you have a patient who's afraid of spiders, for example, they have to realize that most spiders can't and won't hurt them before they can deal with this irrational fear through a cognitive strategy. But we know these kinds of things work. The awareness of thought processes work because we see changes in neural fear responses. There's less amygdala activity once people start increasing their awareness of their fear-based thought processes. Pharmacology can also work in the short term, so drug-based therapy, tranquilizers can help people handle an immediate fear, but when the drug wears off, the phobia typically returns. So if someone is experiencing a fear so intense that it is debilitating, then they can be sort of released from that by a pharmacological treatment, but they then need to seek behavioral treatment to see long-term and sustained recovery. We haven't talked about obsessive-compulsive disorder in our previous videos. It's defined as a combination of recurrent intrusive thoughts and behaviors that the client feels compelled to perform over and over. So I maybe didn't emphasize that sentence very well. Intrusive thoughts and then behaviors performed over and over. So these are obsessions and compulsions, respectively. The intrusive thoughts are the obsessions, and the behaviors that the client feels the need to perform are the compulsions. So a common treatment for OCD is clomipramine. It is one of many in the family of drugs called selective serotonin reuptake inhibitors. These are SSRIs. These are actually the ones that I've brought up previously. So what happens is, serotonin, as you already know, is a neurotransmitter. It is one of those little packets of information that moves from one neuron to the next. And when neurotransmitters, also as you know, don't make it from one neuron to the next, they sort of hang out in the synapse for a little while and then are eventually reabsorbed by the previous neuron. Now, an SSRI is a drug that blocks the reuptake of serotonin. So the serotonin will continue to hang out in the synapse until it is absorbed by the next neuron. So that process, because it's serotonin, can lead to a decrease in some of the symptoms of OCD and also of depression, actually. So combining an SSRI with a dopamine receptor blocker tends to be effective for some OCD patients. But those who benefit from those are also those who have other tics or behavioral tics, or have family history of tic disorders like Tourette's syndrome, which actually has somewhat high comorbidity with OCD. So there might have the relationship between tic disorders and dopamine dysfunction might have something to do with the effectiveness of that particular pharmacological treatment. Behavior therapy for OCD is actually not too different from phobias. So clients are directly exposed to the stimulus that triggers their compulsive behavior, but then they are prevented from engaging in the compulsion. So they feel the intense anxiety promoted by their obsession, but they are prevented from engaging in the compulsion. So it's based on the idea that the stimulus triggers the anxiety, and the performing the behavior reduces that anxiety. Think about someone who has a hand-washing based OCD. That person would then be made to touch a doorknob and be instructed to, or prevented from, washing their hands for some time afterward. Same with exposure therapy for a specific phobia. The goal is to break the link between the stimulus and the behavior. So here the idea is that there is a classical conditioning based association between the stimulus and the behavior, and the goal is to break that, to extinguish it. There are also cognitive treatments for OCD. It helps an OCD patient to sort of become aware of the fact that most people experience unwanted thoughts and compulsions from time to time, but we do not act on them. Those little intrusive thoughts are not catastrophes. They're a normal part of the human experience. And so coaching a person into that realization can sometimes help their symptoms. And actually in the 90s, researchers compared this kind of treatment to, and some behavioral aspects to treatment with Prozac. And both groups of patients showed similar changes, so it seems like both were helpful. And in some more recent studies, it seems like exposure and compulsion prevention is superior to clomipramine, for example, though both are better than placebo. So it seems like the cognitive behavioral therapies probably win out here. They're slightly more effective than medication, especially over the long term. Lots of citations here if you want to look more deeply into that. As we discussed, depression is one of the most widespread of the psychological disorders, especially in the United States, and it is growing. You already know it as low mood and loss of interest in pleasurable activities. There are fortunately a number of effective treatments that we've seen validated through scientific research. There is not like a best way, quote unquote, best way to treat depression, because the treatment approach usually needs to be tailored to the patient. So you need to, we're trying to kind of establish subtypes of patients to try to predetermine what kinds of treatment might be better for people in some kind of subcategories of depression. But in general, most therapists at this point look into all possible venues and see which one works. Prozac is effective. It's an SSRI, but it and other SSRIs have some fairly intense side effects, especially for particular folks, things like insomnia, headache, weight loss, and sexual dysfunction. And there are lots of other drug treatments for depression that have also been validated. They all have varying effects on neurotransmitter systems, some with less serious side effects, which has made them a little more desirable. About 60 or 70% of clients who take antidepressants get relief from their symptoms, and about 30% of people respond to placebos, so they are definitely effective, very effective in fact. But you can also treat depression with some behavioral and cognitive techniques. So you'll remember the cognitive approach to therapy is to make an emphasis on the conscious beliefs the person has and to try to confront them with the irrationality of those conscious beliefs, and then try to change them so that the disorder changes. So as we know, people who are depressed usually don't think productively. They think of themselves as worthless, unlovable. They see no chance that they'll ever improve, that their life won't change for the better, and that clouds their interpretation of otherwise everyday normal events. They see everything through a negative filter. They jump to irrational conclusions. And so the goal of the therapist then is to train a person with depression to reinterpret moments or events in a more positive light. A lot of that you can get from the description of cognitive therapy in the previous video. The treatment for anxiety disorders is interesting. Freud thought that anxiety was the result of a repressed sexual or aggressive impulse. And so he thought that releasing them somehow or talking about them or getting rid of them could lead people to no longer feel anxiety. He thought that was the interesting part, was that underlying cause. And believe it or not, that didn't really help much. It didn't help people deal with their anxiety to be told that they had repressed impulses. Since then, we've seen cognitive and behavioral techniques work very well to treat most anxiety disorders, the same kind of confrontation of irrational beliefs that we were talking about. And medical or drug-based therapies are effective in some other cases too of anxiety, but the side effects are really common, and stopping, once the drugs are done, once somebody stops taking them, it's hard to avoid relapse without some kind of additional cognitive or behavioral therapy. I'll leave you with a tweet I really like from a couple years ago in which this client offers up that his therapist taught him to interrupt anxious thoughts with things like, well, hey, what if everything works out? Or what if my hard work pays off? So he's passing that on to us. I pass it on to you. I hope something goes really well for you this week. I hope that you get an email you've been waiting on or a phone call.